So we're here on our soft start for the eGPlearning live stream, and as you can see, I'm here solo because Andy has decided to run away, and he's now running back. Yes, and he's back. So I hope you're all doing all well out there, out in the eGPlearning lab. And I'm getting some echo, Andy.
Oh, that wasn't happening before. Are you still getting echo?
It's gone now. Sorted it.
Okay,
I realised
good.
why I was getting echo. So yes, I had the thing open in the background and forgot about that. So anyway, bit of a weird start, everybody. Hope you're all doing all right as you come and join us. We're going to give you a minute or so to just settle in, join us and things. And we've got this rather unique and interesting episode that's going to be covering a few things that some of you may have realised, some of you may not have done. I don't know.
Yeah, really interesting actually, because Gandhi has some unique insights that most other GPs don't have into the mind of Katie Brammal-Stainer, because there was an event yesterday in Nottingham that Gandhi and a select few GPs attended. So really interested to talk about that, because I wasn't there. So I'm really excited to see what the tea is. Is that what people say? The truth? So
we will find out. So I think it's time for us to get starting. So we're giving people a couple of minutes to jump in. So let's get cracking, shall we? It's February and there's lots of changes in general practice as ever, but we're going to be talking about one event that happened just yesterday that I was party to, Andy wasn't, so we're going to have some questions on that, but that gives us potential timelines in terms of what happens with the contract for general practice and other things coming up, as well as some extra news stories that, to be honest, are a bit crazy. But as ever, we're going to be here to tech enhance your primary care and learning. Let's get cracking, shall we? Hello, eGPlearners, and welcome to this episode. Myself and Andy are covering the latest and greatest that's happening in general practice in February 2026. And we've got a rather interesting update episode for everyone, haven't we, Andy?
Yes, we have. So really excited about this episode. So we'll be kicking off by discussing an event that happened just yesterday in Nottingham, hosted by Nottinghamshire LMC, where Katie Brammal-Stainer came and spoke to people from the committee, and wider people were invited along, but I wasn't there. So really interested to see what happened there, and if we got any insights into kind of GPC's positioning or rumours about contracts. And then we'll cover some news stories that grabbed our attention. There's been some issues with 14 fish and trainers and trainees. There are some issues with supplies of medicine. Another common one, it was cocodamol last time, it's aspirin today. And also we'll be just looking at a government scheme to improve cancer diagnostics in deprived areas, which grabbed our attention as well. Yeah, so coming to the main event, Gandhi.
Yeah, so this is revolving around, Katie Brammal-Stainer, head of the GPC, is currently going around the country talking to various different areas about contracts and what the GPC has been doing. And yesterday she came to the Midlands region. It was a joint event hosted by the Nottingham and Nottinghamshire LMC, the Derbyshire LMC, and the Leicester and Rutland LMC. So a combination of those three LMCs coming together. And it was a really interesting event, well attended. I think I probably estimate about 70-80 GPs joining to hear about what's going on. And it was really interesting because Katie had the opportunity to talk to those, answer some questions as well. Really well run, I felt. And she gave a clear idea on what she's thinking. Let's put it that way. That's for sure. So yeah.
Gandhi, I've got loads of questions. The first one is an interesting combination of LMCs. That's our kind of new kind of ICB footprint, isn't it, across those counties? Are the LMCs starting to work together a bit more now to reflect the new footprint of our new combined ICB?
Maybe. I think this may have been more about geography than anything else. So the venue that they had happens to be the intersection of all three LMCs, and I think there's probably some collaboration going on between the LMCs. Been fortunate enough to work with all three of them. I'm part of the Nottingham and Nottinghamshire LMC as a constituent member and representative, but I've also worked with the Leicestershire and Rutland and the Derby and Derbyshire LMCs as well. So I know they all do really good work to try and help their member practices, and I think this is mainly around trying to bring that voice and that awareness to the local profession.
Yeah, but I just think it might be a need to work together more. If the ICB is getting bigger, maybe LMCs need to work together on a bigger block. But I guess that's a bit of a side story to the main event, which was sort of KBS was here. Was she here on her own, or were there other members of the GPC?
No, she came by herself. So travelled up. I can't remember where she was travelling from, because I know she's doing a bit of a roadshow at the moment. And yeah, really interesting event, and lots to mull on, shall we say.
Okay, so I guess kind of, so what happened? So I mean, like, did she give a speech? Did she just take Q&As? Like, what happened? And then after, I'm interested in the content.
Yeah, so she spoke for probably about an hour and 10 minutes, I think, in total. A majority of that was talking around some slides that she had and some information that she went through, quite structured in some ways, but also lots of ad hoc kind of motions and comments and stuff. And then throughout afterwards, we took questions as much as people could manage, because as you can imagine, this was after work, it got quite late, didn't end up leaving till about 10 o'clock, for example. And yeah, it was well run in that sense. I think the topics that Katie talked about, I think she addressed a lot of the questions I know I had in my head, and I think very much tackled a lot of the questions that people had for her in terms of what was going on and how that was feeling. I think for many of the audience, that the tone was interestingly led. So, the organisers used Mentimeter to try and gauge the tone before the event. I would mention kind of had to. So one of the interesting things about the event, I ended up being the Chris Whitty situation.
Okay.
So next
slide.
Yeah. So remembering to have all the kit that you need to host an event. I know me and Andy do that on a regular basis, but had to bring out a variety of dongles and stuff to try and connect all the tech up with them and stuff and things. So, and yeah, I was the slide pusher for the day. So.
And Gandhi, before we get into like the content of what she said, another thing that I'm curious about is like, what was the kind of attitude in the room to like GPC, BMA, and I guess to a certain extent KBS herself, because relationships with the Department of Health have been like really strained, and there's also been some questions around the handling of the e-consultation opening times. So I was just wondering, like, what was the feeling in the room in terms of kind of faith in the GPC? And
yeah, no, I think there were definite questions to Katie in terms of some of the things that you mentioned, particularly in terms of the online consultation, which we know has been quite a challenging part for many of the practices and general profession itself to respond with, in terms of how that's particularly been handled. I think there was definitely clear outlining of motives in terms of where different parts of the contract have come from, what may change in the future in terms of some of the asks and stuff, as well as what actions the GPC are considering in terms of moving forward to try and understand what the profession wants. And I think that's probably the key stuff that Katie kept emphasizing, that there is going to be transparency moving forward. There's going to be engagement. There's going to be the opportunity for the profession to have its voice heard.
Okay, yeah. So I guess let's launch into what were some of the kind of highlights or kind of key things that emerged from discussions.
Yep, absolutely. So I guess just before we get into that, so if you are watching us live, feel free to ask your comments and questions. I'll try my best to answer whatever we can. And if you happen to be watching and were there last night as well, let us know. That'd be awesome. So I think the big thing that I took from this, and this is very relevant for me and you, because this is the thing that we cover every year, is when is the contract coming out? Yeah. So it looks like it's currently with the government, being processed through the various departments and stuff, and likely to come out towards the tail end of February. So it looks like we have a timeline of the end of February where the contract will be released for public.
GMS.
That's the GMS contract. So important that you mention that, because I know there are other contracts that people are thinking of and waiting for and stuff. And it looks like that will be the GMS contract that comes out at that time. It seemed to suggest not to expect miracles. So we had an 8.6% uplift last year, which was very much a stabilizing kind of contract. And Katie talked about how that was agreed and why that was felt to be okay at the time. because it was very much with a view for stabilizing general practice with various things that happened. Obviously, the biggest ones like last year was the significant rise of inflation, national living wage going up, and national insurance changes and stuff. So an element of trying to provide some stabilization of general practice, but it's looking like there won't be that level of uplift this time round either.
And so have the GPC seen that contract, which is now
I'm assuming they've seen it. Now, Katie did not give any details as to what was in that, and I suspect that there are reasons why she's not able to do so, because people did ask and she wasn't able to say. So
did she seem pleased with it? Sorry, I'm probing, Andy. I feel like I've got you on question time or something today, but did she seem pleased with it? You know,
I think she said. I think her exact words were, "Look at the medium-term framework, and then think about what that says."
Okay.
So I'm going to leave that with you for a second, Andy, because I know we've covered the medium-term framework, and people do want to see what that is, and it sounds like that's going to be the guidance for a lot of the stuff coming through. And we even mentioned that when we covered it, that this looks like the plan for the NHS moving forward. It seems that some of the contract stuff will be focused potentially around the medium-term framework for the NHS.
Okay. And so we think so. Like February is like really early for the contract to land, because it's normally
compared to previous years. It is,
right to the wire, you know, to April. Do we think this one is another kind of placeholder, kick the can down the road, more, you know, fundamental changes coming in the future sort of contracts?
Yeah, I mean, that's the impression I got from what Katie was saying, that this is very much again another placeholder contract. We're not going to see significant transformation coming through from this contract, but actually her view is very much that the aim is to look at the transformation contract, which is the transformation of GMS itself. There's the current consultation that we know about in terms of Carhill. That's unlikely to report into this. So if people were expecting Carhill to be reevaluated for 26-27, it doesn't sound like that's going to be possible. But then you and I both have a rough idea of how this works, that realistically, if that consultation finishes in end of Feb, early March, which is, I believe, the time frame it's on, that's not going to be enough time to put that into a new contract for 26-27. So it's likely that will then factor in either to possibly October, I guess is the earliest possible time frame, or more likely 27-28.
Okay. And I guess the other, just while we're talking contracts, the other contracts that we're waiting for are around neighborhoods, small neighborhood provider contracts, multi-neighborhood provider contracts. I guess any indication of when they might land, and also like what does she have to say about them? Because the BMA is worried on behalf of the profession about those contracts.
Yeah, and I think there's been some news stories about the fact that the BMA seem to, be quite clear about how those contracts come through and what they need to look like and stuff. And comment from, I'm afraid I'm not even going to be able to pronounce that handle and things, but we've heard rumors that we won't see SMP and MMP until 27-28. That was partly the impression I was getting from Katie as well. They're not coming out imminently. Whether the outlines for them may do. And rather interestingly, I did see a post today where they were saying that the NHS contractual terms have been updated, which include the reference to the terms SMP and MMP as contractual terms within the main NHS contract. So it might be coming through, but whether it'll be operational is another question. And I know we raised that with Minal when she came to visit us and stuff, as to what does the neighborhoods look like and stuff. And there's a suggestion that operationally ICBs might have to have neighborhoods up and running by October, but we still haven't
without the contractual framework. It's a big headache for those people who are working on these sorts of projects within places and ICBs.
Yeah, that would be you, wouldn't it, Andy?
That's one of the projects I'm involved with. So yes, we could do with knowing what's in the contracts as soon as possible, really. So, but I guess from the BMA's perspective, on behalf of the profession, I guess the worries are that value might move from GMS contract to SNP, MMP contracts, either as a block or, over time, just kind of leach away, or kind of additional funding just goes into those contracts. So I guess that's a concern. And then they're also worried about that potentially being an alternative contracting mechanism for the delivery of traditional general practice, because some of the language in the 10-year plan spoke in those terms, particularly where traditional models are not working, then this is an alternative. I think the language went something like that. Did anyone ask, or did she go into any kind of more details about like concerns that they might have, or what the BMA might be doing about that? Or
I think those concerns are always going to be there. I think the point that Katie seemed to mention was more around the logistical ability for that to actually become a reality. Not because potentially the government may not want it to happen, but actually, and this is one of the things I think a lot of people currently are forgetting, because of the ICB transformations that are currently happening, with many people looking at, the 50% cuts that the ICBs are having to make, and, within NHS England and various other things, actually, a lot of the doings kind of stopped. And as a result of that, operationally getting things over the line, that's the reason why it's taking so long to happen. That actually, who's going to hold the contract? How is that going to work? Who's going to make it happen? I think there's lots of questions around that, and because people are leaving, people don't even know who to ask about it at the moment. So it seems that potentially they've shot themselves in the foot by trying to make this happen, by doing the ICB cuts, by doing the NHS closure of NHS England. That actually that is the reason it's slowing down so much, more than anything else, because there's no ownership and there's nobody to do the doing of getting this all over the line.
Yeah, I get that actually, and the interesting thing is, kind of the sort of people I'm just thinking locally who are kind of currently trying to get that over the line. They're people in the ICB who it's maybe unclear, whether they'll still be in those positions going forwards to continue that work of delivery. So I can kind of see that maybe the system needs to have reached a position of a bit more stability before it's ready to accept and hold those contracts. There's perhaps a little bit of, they use words like market shaping, don't they, to get the providers into the right kind of position and posture to be able to hold those contracts. Okay, right, okay, interesting. Maybe going down a bit of a contractual rabbit hole there that we like. So what else happened, Gandhi, or what were some of the other themes?
So let's talk about collective action, because I think that was something that was felt very strongly by many people in the room. A couple of years ago, roughly that time, we had lots of action on collective action, and it seems like currently the discussion with the profession has quietened down. Let's put it that way. And I think Katie very much took it that actually national collective action, stopped in the sense of a combined route forward. But that didn't mean that local collective action haven't stopped. And actually, there are some examples in different footprints and stuff where, areas have been able to negotiate good rates for work that actually needs doing by general practice, and so it's appropriately remunerated. And I guess if people want to know more about that particular aspect, definitely join us next week for the episode I do with the Medics Money team, where we talk around a lot of the financial prudence that people probably need to look at and stuff. So that's going to be an absolutely great episode, and some cool tips and stuff in there. But I think in terms of where was I, Andy? Sorry, lost it. Contracts.
So oh gosh, I've lost it as well. Where are we
going?
I
just saw some of the comments coming up and I got sidetracked on the comments. So whoever
go comments. Bring the comments in, and we'll pick.
Okay. So apologies. So the weird name I couldn't say apparently is Kyle. Hi Kyle. Hope you're doing all right there, and stuff. So I have lots of colleagues who've been around saying it's like previous changes where they've laid off people and rehired, but it feels different this time as ICBs are staying and they're just being cut, which is a bit which I agree. I think there's lots of places where people are looking at losing their jobs, which is devastating. And I know we covered up previously on the channel how West Streeting was almost elated by the fact that this was going to happen, but that's a different perspective, I think. But I think with how we're seeing those changes, it does feel different in terms of that transformation work. I think the concept of how contracts are coming back, how things seem to be going upwards, downwards in terms of strategic commissioning for the ICBs. I think other organisations coming in, that feels like it's happened before. It's just a different name for different things. So the ICB is now going to be the SHA, what the SHAs used to be. Are the collaboratives going to be a different version of fund holding? I don't know. It feels like we're going around in a circle again to some degree.
I agree. I guess where there's more of a question mark in my mind this time is whether the funding will be there to follow the functions that are moving, in theory down into providers. Whether actually the funding will be there to absorb those activities, and then will the staff move with that activity? Does 2Pay apply, transfer under existing terms and conditions? I don't know. I'm not an employment lawyer. Gandhi, before we went to comments, we were talking about collective action.
Okay.
I've got a question actually, because I was talking to James, one of our salary GPs, who was at the meeting.
Who hosted it very well. So I mentioned about the hosting. James, Andy's colleague who works in his practice, was the host.
He's very charismatic. So he was talking about collective action, and what he said he thought he'd heard is reflections that kind of collective action where people had 10 different activities that they could choose to or not choose to engage in for collective action, or do any combination of them, led to a bit of a patchwork of collective action that maybe wasn't as impactful as if everybody just did the same 2 or 3 things, and that maybe the BMA was considering a different approach, perhaps with a more limited palette of possible actions. Is that true, or maybe James was kind of, his imagination was running away with himself?
No, I'd agree. I think that's very much the flavour that Katie was mentioning, and I guess the evidence behind that is actually something you and I got involved with. I think you may be on the back end of it and stuff and things. So people may remember the GP update record saga that happened in summer last year, whereby was it last year or the year before? I've even lost track now. Time's flying. But effectively, where Katie commented that there was going to be transfer of information happening through the GP update record, and that this was not agreed by the BMA and the GPC, and actually asking practices to switch off that connection to the GP update record. So this would have been in 2024. Clarity on that. And then as a result of that, pretty much the entire profession, pretty much almost every practice in the country in the space of a weekend switched it off. And more than anything, that was a show to the government of the will of what happens within the profession. And I guess that's the key part that, like you said, James was taking on, that asking the profession to do one action, one focused piece of thing, seemed to have more of a resounding impact rather than giving people a suite of things. And I think there's that question of asking people to do things that they feel are appropriate and safe for their patient care, but also confident that they are not going to have aspects of liabilities that are harder to then judge and manage as a result of it. And I think we may see a stepwise progression of those collective actions. So I don't think the first thing will be shut your doors, which I know is what probably a lot of people are talking about, asking about, should we just close? And I guess part of the reflection that came from the room was very much that actually general practice closing its doors for one day is, it'll have possibly some impact, but how much impact will that actually be? Because we close for the weekend, for example. General practice closing for a week, that's a different matter. But then what does that mean for those practices that make that decision to close for a week? Because you and I both know that's a breach of contract.
Yeah, that puts you in a really difficult position. So yes, I guess some of those options around data flow, data controller positions on non-patient safety affecting issues, could be places for action. Actually, that's really interesting to think about that. Okay, anything else that came through on kind of collective action? Because that's potentially going to be quite a big issue going forwards, particularly if we have an imposed contract.
I have a feeling that a lot of the actions that primary care is going to be asked to do are going to be very nuanced and probably stuff that people don't feel is going to be impactful, but probably impacts the system in different ways. And if we go back to the collective action, interestingly, it was the stuff around prescribing, it was the stuff around engagement with letters and stuff that actually had the most impact in terms of collective action, even though it may not feel like it does something. Because actually it affects different parts of the system in different ways. The prescribing budget is actually one of the things that general practitioners have quite significant impact on, but not having direct responsibility of. And it'd be interesting to see how that goes, because actually we make financial decisions on prescribing and stuff based on cost, effectiveness, clinical value, but that, you know, they are combined aspects because of the aim of trying to save the system as well as trying to help the patient in front of you. Imagine if you just focused on the patient in front of you and less on the cost, and actually that could have a resounding impact on other things. And unfortunately, part of that we're already seeing as a byproduct just because of the supply issues, which we're going to talk about a bit later on anyway. But yeah, I think prescribing is going to be one. I think data is going to be another, because we know that data is key. Particularly, you know, general practice is the richest source of data in the world.
Yeah,
you know, there is very few data resources better than general practice health data.
Yeah, and there are lots of applications for that data that are about kind of monitoring performance within the system rather than needed for patient care. So there's probably some scope to take action on those issues. Okay, any other kind of big kind of themes around the questions or the statements that were made last night?
So I guess the one that I took up was this timeline. So February is when the contract's going through government. It's probably going to come out to the profession end of February. So I guess me and you need to be available at that time.
Yep, to look through it.
And speaking of that, so during February and March, myself and Andy will be switching to going to Saturdays, not because of the contract necessarily, although that's a fortuitous thing, but mainly because I'm going to be fasting and therefore, you know, going live in the evenings is a bit trickier. But it sounds like there's going to be a referendum for general practice on the contract. I think the GPC are going to come to the profession to ask our views on would you accept this contract. And I think it's going to be broader than partners this time around as well. So, you know, there was no certainty, but it sounded like this is going to be wider than just partners.
That's interesting, isn't it? And so the actions could be taken by others, because the reason it was partners last time is because partners are the contract holders and and therefore kind of positioned really to say what their practices were going to do. They're the ones who hold the contract risk for non-delivery on those contracts and breaches on those contracts. But yeah, just I think I need to get my head around. I understand how it feels fairer for everyone, including salary GPs, to have their say and potentially locums even. But then when it comes to like delivering on those actions, you know, quite a lot of that ask could go to partners. Interesting.
Very much so.
We'll go into detail.
It does come into that nuance of the fact that because general practitioners are contractors to the NHS, are providing the contract, and therefore the staff working are, if they were to go on strike, they'd actually be striking against their employers, which is the practice owners, not the NHS, not West Streeting, not DH and that kind of thing. So it is a weird nuance that people struggle with, but that's part of the reason why the risk and responsibilities with the partners who own the practice. Although remembering that, as usual, according to the Treasury and West Streeting, general practice is not part of the NHS, apart from when we deliver 31 million appointments every month, you know, and stuff, and you know, a massive amount of impact. I do think as well that there's this interesting dichotomy in terms of what we're going to see in terms of how general practice is coping with demand. And I suspect there's going to be an ask for general practice to do more as ever. I mean, we've seen that time and time again. Every contract we've had, we're giving you something, but we're going to ask you to do a lot more stuff as well. So I get the impression there's going to be a bigger ask, potentially, you know, urgent demand. And that's going to be an interesting part, because remembering that general practice is not an urgent care service.
Well, that's what I always used to say. I'm not sure that that's quite so true anymore. But that's what I always used to say to patients, you know, or found myself often saying to patients. Gandhi, I guess KBS may or may not have took questions on this, but she obviously has dealings with people in the Department of Health and NHS England, and those two organisations are going through a lot of change at the moment, with NHS England being abolished and some of those functions being absorbed into the department. Like, does you know, did she give any window into what that looks like? Is it more?
I think it's still being worked through. There was definitely talk about how the fact that NHS England seemed to have better terms than Department of Health, so whether that will lead to an attrition in terms of who's working where and what that looks like, and you know, transferring those that are continuing and NHSE onto Department of Health contracts? Will they stay? Will they go? It seems interesting to hear some of that context about what might happen in those departments. And, we're seeing lots of wider impact of some of the current news cycle stories and that kind of stuff in terms of what's happening. Even grumblings, is it going to still be Wedge Streeting? Maybe, who knows?
Will he be the boss?
Yeah. Well, you and I have, unfortunately, over periods, we've covered the fact that we've had more health ministers in some timeframes, than most people have cars or whatever.
Yeah, yeah. Okay, well, we will see. So, anything else that came up, Gandhi?
I think that's a fair amount of what was covered and stuff. So very much, I guess, just to summarize, that there seems to be a timeline for the contracts, February, moving into tail end of February, and then looking like March will be a decision time for the profession to have their opportunity to talk about things, that there is working up some plans of looking at what collective action may look like moving forward. I kind of get the impression the BMA is not impressed with the contract, and it may be imposed again.
Okay, be interested. Yeah, so I was kind of fishing for what she seemed to think about it and if she'd seen it, but cards close to chest by the sound of things.
Potentially. I mean, you never know, things could change. That's the whole point. Until the contract comes out, we do not know. But I guess the key thing I heard was not seismic shift. That's not this year, which we kind of had an idea of at this point in time. To be honest, if there was going to be seismic shift in contractual aspects and stuff, it had to be out sooner, just because trying to operationally make that happen is almost impossible. I think maybe some ideas as to how that might work and function, but it's whether or not Treasury and Department of Health would accept those ways of making things work. So let's talk about the CAPE funding, that actually bringing that back to general practice rather than that being at PCN level may help to operationally make practices more stable. I think other mechanisms of what does working well moving forward look like in terms of, should general practice become an employed profession or not, and actually some of the dangers of that happening with trusts and various other aspects and things. So, is it that people are thinking if we were to become employed by trusts and stuff, we'll be on consultant level contracts? Actually, what's to stop people being put on trust grade contracts or middle grade contracts or junior grade contracts? Because let's not forget, GPs are often treated like junior community house officers. What's to stop them being paid for those ones by a trust if they wanted to, because that's the terms they were going to offer. It's an interesting time.
It is interesting times. Okay. So, and I guess it's been mentioned in the chat that there are rumors that the MNP, SMP contracts may be next year as well. So I think we can say, some people are saying that that's going to be 27, 28, if people are wondering about this contract. But we don't really know. I think we've got no idea really when they will come, but that's what some people are saying. Okay, cool. Sounds like it was a good event.
Yeah.
So it's a shame I wasn't there, but I feel you've brought me up to speed, as you have everybody else listening, hopefully.
And I guess just to mention all that, so Katie is still going around doing roadshows across the country. So if you have the opportunity to hear it and you want to hear it, go. Fortunate enough that I know Katie quite well. Proof of that. So if people do want it, I know Andy's got it on the screen, but I haven't shared it yet. So that's me and her yesterday. As I said, I was her Chris Whitty slide mover person for yesterday and things. And I think we also have a photo with the LMC as well, don't we, Andy? So just to mark that it was a group event and amazing work and stuff that the team did. And hopefully that was well received by the profession in terms of stuff and things. But yeah, great event. And I think Katie's an amazing speaker when you hear her talk and stuff, and you can absolutely see the passion that she has for the profession. And I think, there's lots of things that have happened more recently that, raise some questions about what's been happening. I think for me, I have some more excitement after hearing her talk about what might be coming for general practice, and at least, some potential. That's not to say that some people weren't feeling a bit dejected. It does also sound a bit gloomy as well, to be honest.
It does. That was quite a gloomy conversation, really, but maybe brighter times ahead, perhaps.
Yeah.
Well, let's see. Let's see what happens. Okay, so let's have some fun. So wavelength.
Okay, let's go for wavelength. Yeah.
So wavelength. So something that we started doing on the podcast. I actually really, really enjoy this. So this is the wavelength indicator. We will spin this dial so that it will, very loud, isn't it? So that it will land somewhere on a spectrum from 0 to 180 degrees, actually probably more like 10 to 170 degrees.
Something like that, yeah.
And then, so I'll spin it. I'll know where that is. I'll close the shutter. And then I have to make a statement to Gandhi to convey where the strength of my statement is. By the strength of my statement, from one side of the spectrum to the other, I have to send Gandhi a signal, and then he will say where he thinks my statement lands on that spectrum. It will become more apparent when we actually do it. So you ready, Gandhi?
I'm ready. Let's go for it.
Okay, so so it's all a bit back to front. So this is 0 degrees. Does that work for you?
Yep.
Yep. And then this is 180 degrees over here. And at 0 degrees is a type of industrial action that will have practically no impact. So doing nothing. Okay.
Okay.
At this side, on the other side, we have industrial action that is like, chaining the doors closed. Okay. That is about the maximum that we could do, sort of stop working in general practice. And I'll kind of try and convey where I want Gandhi to guess on this spectrum. So I'm going to spin it. Going to have a look. Okay, fair enough. And so this is do nothing. This is change the doors closed. I'm going to say, I have to have a think. Okay, I'm going to say.
So whilst Andy's thinking, I'm just going to go to a comment that we've had. So this makes more sense with video. I'm kind of curious to know, I think that's Kyle again, whether you mean this particular section of wavelength or whether you're talking about Katie's stuff and things. So hopefully that gives us an idea. But Andy, have you got a clue in the meantime?
Yeah, so I'm going to say refuse to engage with pre-surgical patient optimization, optimization of patients pre-surgery.
I'm gonna go. Let's go for 70 degrees. It's a bit further. Yeah, a little bit more. Bit more. I think. Okay, maybe that's not 70. That's probably more like 80, isn't it? Yeah, about there. No. But where you were before.
Okay. Yeah. Fine. Right, we'll come back to that later and see.
And we will remember to come back to it because last time we didn't. I can't remember what we did. So we will definitely come back to that. But just before we do, we're going to cover a few other news stories that are quite interesting and relevant, I think, particularly to stuff that we've done and things. So first off is something called I'm calling the 14 fish fail. Okay.
Far away, Gandhi. You're a trainer, so you'll be closer.
Yes. So, this has relevance for me and Andy for a variety of reasons. Me specifically, because I'm a trainer. But basically, there was concerns raised about the 14 fish platform. So this is a platform that is used for a variety of things. Its main use is as the e-portfolio for GP trainees, in terms of them having marked all their competencies and all the other stuff that allows them to progress through GP training and then to be signed off, and it's how they communicate with the trainer, i.e. me. Also, a lot of GPs use it as their appraisal toolkit as well. So, it has doubles up, and I think it is also used for other parts of the profession, like paramedics, etc. and stuff. The issue came, so there's a couple of things that have happened in this. So last week, the entire platform was down for period of about 12 to 24 hours, I think it was in total. But the reason why this was frustrating is because yesterday, as in Wednesday, was the last day that trainers should be doing their educational supervisors reports with their trainees. So typically, all the trainees in their normal syncing timeframes should have had their midpoint reviews, and some of them that would have been their final point reviews, for example, being done. So normally you probably plan that for a week or two before the deadline. Last Wednesday it went down with very little warning, and you couldn't access it. So it's like, how you want to go pay your tax bill, and then a couple of days before, your banking website goes down and you can't access it. That's kind of how it felt.
That would be frustrating.
Yeah.
Are you speaking from experience there, Gandhi?
Well, thankfully, that particular situation has not happened to me to that severity. But yeah, it's a frustrating thing to happen. And it was very much something that evolved. So initially, it said it'd be up at 12 o'clock. Then it said it'd be up at 3 o'clock. Then it said it'd be up at 5 o'clock. And I believe it was up shortly after 5 o'clock in the afternoon. However, like for example, for myself, Wednesday is the day I spend a lot of the time doing other things like eGPlearning and my training and stuff. That day had gone for me to meetings with trainees to sort out their portfolios and stuff. That was gone for me. The other change, which is a rather more interesting one that's happened, is that 14 Fish have now required assessors, so people who are doing clinical supervisor reports or assessment for trainees, to now create their own 14 Fish account in order to complete those assessments. Okay.
Oh, and pay for it?
No, so they don't have to pay for it yet, I think. But here's why it's interesting. So prior to then, if, say, for example, Andy, you had a GP trainee that came in and you did a assessment of their ability to do a chest examination and stuff, they would then say, can you complete that as an assessment for me? And you'd be like, yeah, fine, no problems. They will then send you an email. That comes with a link. You click on the link, you fill the assessment, you're done. Yeah. Now, when you click on that link, you have to put your details, create an account with 14 Fish, so giving them your data. Yeah. And then you can complete the assessment.
Okay. And do we know why they've done that? Is it so that they can make sure that you're who you say you are, and they ask your GMC number? I mean, they could do that anyway, I guess.
They could. And part of the form does ask people to attest that they are suitably trained and competent in order to assess the person for that particular reason. That was there beforehand. You could argue there's an extra element of verification that now comes into play. But the interesting thing, and this actually has happened, I've heard of many trainees who are now struggling to get people to complete the forms because a lot of people are just seeing that as a barrier to entry for them doing it. And therefore, as a result of that, people are not completing their assessments.
Sad. Yeah. And so Gandhi, so it's interesting. I'm not involved in training GPs, but I guess, training is a necessary, the completion of these portfolios is necessary for training, part of the RCGP membership pathway. So how is it that kind of a private company is positioned within that pathway and is able to make these sorts of changes that affect what trainers need to do and how trainers behave and how trainees behave? Like, it just seems a little bit odd, maybe. Why is there not an RCGP platform for this?
So I guess the reason why there's not an RCGP platform is because probably the cost of creating it themselves was more than they felt they could bear. And weirdly, I was the trainee representative on the ePortfolio way back when, if you go back about 10, 15 years or so ago. And very much that was the question at that time, that at that point, they were still paying off for 30 Euston Square. They had other liabilities and stuff. There was just not enough resources to maintain and fund a platform. It used to be with Clarity, then changed to 14 Fish, several years ago. And now they have a partnership with 14 Fish who now run it. I think the question of, is this change been agreed by the college? I don't know the answer to. I genuinely don't know. As to whether that was something that was initiated by the college, or whether that was a 14 Fish thing, or if there's anybody who's watching us live and can tell us, please feel free to do so. But it's an interesting change that has definitely caused an impact. And speaking to my trainees as I've done their reviews and stuff, many of them come to me and said, I can't get people who don't use 14 Fish on a regular basis. So obviously I have an account because I have to have an account in order to evaluate my trainees. But that doesn't mean that everybody else has. And that part of the question has now raised an issue for trainees completing their assessments. And it's made the barrier to entry so much higher.
It's interesting, isn't it? It feels like the sort of thing that kind of a well-meaning developer with an interest in, upgrading the security of this service to a higher standard might implement in a very well-meaning way, but not appreciating the knock-on effects that it would have. And I guess there not being a process in place to evaluate the impact of these sorts of changes. Increases in security can often increase friction in systems and can be quite annoying for users. Wouldn't be the first time.
Part of me very much wonders if Carl's got the right comment here, though. So 14 Fish is owned by EMIS. No. So EMIS parent company Optum apparently is in the process of a buyout by another company. Is this a way of increasing the value potentially?
It's some more data.
More data. We know data is key. So yeah.
Maybe, I don't know. My bet's on well-meaning web security people not understanding the impact of what they're doing. But who knows? So yeah, it's an interesting story. I guess we'll watch this space, see if they row that back. Probably won't.
So next news story we had is a follow-on from one we covered last time. So last time we talked about cocodamol drug shortages and the impact that was having on general practice. Unfortunately, there are more drug shortages coming, and this one's probably even more impactful, which we didn't think was possible, did we, Andy? But this one's going to be even more careful.
Aspirin. So aspirin, really, really common, most prescribed for cardiovascular prevention. And 9 out of 10 pharmacies in the week commencing January the 13th were unable to supply aspirin to their patients, which sounds ridiculous. That's 86% of pharmacies. Shortages have caused the cost of a packet of 75 milligrams of aspirin to go from 18p last year to £3.90 this year, which sounds ridiculous, but I guess supply and demand mismatches will do that to things. And the maximum reimbursement that pharmacies can get, I think somewhere within the article it mentions, is £2.80
something.
per packet. Yeah. So pharmacies would at the cost of acquiring it for £3.90, they'd be losing about £1.70 for every packet that they dispensed. So I guess just highlighting there are medicine supply shortages affecting all sorts of really common medicines at the moment. And then I think the National Pharmacy Association kind of also wanting to make that point at the same time, that the cost of dispensing a medicine is often higher than the cost that they can claim that back on NHS drug tariffs. So they often do a lot of their dispensing at a loss. So there's some comments from the National Pharmacy Association about how the system is somewhat broken as well in that regard. But yeah, interesting, another common medicine out of stock.
Quite scary, to be honest. I mean, one of the most common medicines utilized in healthcare, and one of the ones that potentially could trigger, heart attacks, strokes if people weren't taking it.
Doesn't really talk about why it's short on supply within the article. I don't know if you managed to skim that.
From reading around the subject, and please don't hold me to this because I appreciate it's my interpretation of it. It's down to the reimbursement tariffs that the NHS are paying for these drugs. So the suppliers are going to other countries and they're just selling them elsewhere because the NHS is not reimbursing them to the level that they're getting from other places, and therefore the supplies are just dried up as a result of it.
Okay, that makes sense. I can appreciate how that mechanic might be at play. Okay, and then so I suppose we can maybe end on a slightly brighter story, I think. So this just caught my attention because I know that we both work in areas of higher than average deprivation, and government has announced another 200 million for increased cancer screening in deprived areas. We'd sort of linked out to the government announcement on the government's website. So often what you find is these stories in Pulse or other places, if you kind of just either click through to the link or research around, they're often driven by documents that come out of NHS England or from the government. So they've done a press release talking about this. But it does look like there's 200 million of new funding for a 3-year neighbourhood early diagnosis fund. And it said the press release is a fairly interesting read in a way. They highlight the link between deprivation and premature deaths due to cancer. So people in Blackpool, for example, there would be 208 per 100,000 people per year with premature deaths due to cancer, compared to, say, Harrow, which would be... So Blackpool is an area known to have high levels of deprivation, and Harrow is an area known to have low levels. So 208 per 100,000 in Blackpool and 104 per 100,000 people in Harrow, one of the most affluent areas. So that people are having twice the chance of having a premature death due to cancer in the deprived area of Blackpool, and those patterns are repeated, consistently across areas of low and high deprivation across the country. So this is an initiative designed to sort of partly redress that by investing in early cancer diagnosis schemes in those areas. They talk quite a lot about lung screening of at-risk individuals, so smokers over 45, for example. I know in Nottingham, I think we were one of the trial areas for what was locally called lung MOTs, so identifying that cohort of people, inviting them to mobile scanners that come to their local areas, so it's really easy for them to get to and do a CT scan to look for early cancer-related changes in the lungs, and I think those evaluate very well. Those do pick up cancers early and allow for intervention that saves lives. So it talks about that sort of screening. There are a few other types of screening in there, but just thought it was it's a positive, isn't it?
Very much so, and well timed with World Cancer Week, I believe it is this week. Partly because I know that we're doing an event in my local community in our mosque to promote cancer screening and things, and nationally there's been obviously fair amount of plans being raised. There's the commenter, and I apologize if I've got the headline wrong, something about trying to prevent 75% of cancers by 2035 or something like that. So I can't remember the exact term of the cancer pledge or whatever it was by the government a couple of days ago, but this is a positive story, absolutely. And it'd be good to see how that works, and keen to hopefully see that it does deliver on what it's asking. So this is the cancer fund, as you mentioned, Andy, there on screen, coming through from the government's page. So I think it'll be really positive stuff to see. And yeah, 200 million, like you said, for local cancer care to address the gaps in screening uptakes and stuff. Because we know that screening can pick up, particularly breast, bowel, cervical cancer, those rates. And we know that they are generally lower in areas of deprivation.
Yeah, and early pickup improves survival. So so absolutely need to drive engagement with those, and some of those additional schemes will be really useful as well. So
wavelength.
Okay, so wavelength. So on this side, this is so industrial action from GPs in terms of impactfulness. Do nothing, chain the doors closed, and to communicate the position on this dial, I'd said to Gandhi, practices refusing to engage in optimizing patients' health pre-surgical intervention, something that I guess is good practice, and something that increasingly there's a focus on in terms of I guess supporting patients in their journey through to secondary care. So and you said about sort of 70-80 degrees. Shall we see where I was? Ooh, we need some music.
Oh no.
Well, yeah, I mean, with the same end of the dial, so I'd thought that probably no one would be that's not going to get us a renegotiated contract and would be fairly ineffective. But same side of the dial. I'll take that, really. I think it was a tough one to think of something to communicate that. So I wonder how people at home did on that, and whether they were in the same place as Gandhi. Well.
And I guess if you enjoyed that, so it looks like Kyle definitely does. So he was asking videos, all the wavelength segments. Yeah, we could probably go back and make our own episode just on the wavelength episodes. Yeah, I need to find the recordings and do that now. See, Kyle, you give me a challenge. I might have to rise to it. I guess other things that are coming up very shortly. So if you haven't already registered, then do so for our GP5T11. That's this Saturday, our remote conference for GP trainers. Showcasing some of the amazing talent in our faculty of being able to cover various different topics. I mean, we've got sessions on, if you've got multiple hats as a GP trainer, how to handle that, AKT, SCA stuff, because, the exams are important things, as well as various other aspects like the untaught medical curriculum and the opportunity to ask our panel anything, as well as various other sessions as well.
The untaught medical curriculum. That sounds fascinating.
Oh, it's going to be great. I'm so looking forward to this. And then Ed Pooley, as ever, our regular, who's been at every single GP5T conference, talking about the impact of social norms on GP training and stuff. So, if you do want to join us, feel free to do so. It's an amazing conference. It is cheaper to sign up now because I do charge more if you sign up afterwards. And I always get these questions about a couple of days later saying, I didn't see it. Can I get the recordings on? Yes, you can. But because it takes a lot more work for me to make that app, and I'm afraid we do charge you a little bit extra for that pleasure. And plus, to be honest, we'd much rather you join us live because we have so much fun delivering this conference, don't we, Andy?
We do. It's a great Saturday morning. It's good. You can sit down with coffee in your own environment and engage with it. It's really fun.
Yeah. So if you want to join, sign up there. Additionally, we have our own other conference that me and Andy are doing, which is our PCM Plus Live 2026. That's in Nottingham, 22nd of April, with Ben, with Tara, who we do the PCM Plus stuff. This is deliberately positioned after the contract is out. So it sounds like it's coming out a little bit earlier. We'll have a little bit more time to digest it, but with that as well, there'll be other contracts coming through, neighborhoods, maybe SMPs, MMPs, all that kind of stuff. But you'll get me, you get Andy, you get Ben, you get Tara, and you also get some additional extra amazing speakers who get to talk about the whole thing. In fact, we've got our update planning session tomorrow morning to talk about the conference as well. We've got a venue. We've got people signed up as well. I think there's about 70 people signed up already.
That's amazing. Yeah.
Yeah.
And what I'd always like to stress with this conference is, great facilitators, great speakers, really, really great delegates. Those people going will be primary care network clinical directors. There'll be people working in leadership positions within ICBs, places, federations, digital transformation managers. Like, it's really quite a good caliber of people there. So you can learn a lot from the other delegates there. And also it will be held at the Jubilee Hotel and Conference Centre on Nottingham University Innovation Park. So the venue is really, really good. Just had a comment. Is it in Nottingham? Yes, it's in Nottingham. It's at the Jubilee campus, if you know where that is, in Nottingham on the Innovation Park. The venue is really, really nice. I did a site visit a few weeks ago. So it's quite a nice classic conference. Good. Come along.
And just for clarity, so the PCM Plus conference is in Nottingham. The GP521 is completely remote. You don't need to travel. You don't need to do anything. You just need to log in from the comfort of your own home, and you can have a cup at the same time if you want to. So we've got loads of stuff coming up as ever. In the next couple of weeks, you're going to see some extra content coming from us in terms of various aspects. I've got, like I said, we've got the Medics Money episode that's coming out. Honestly, it's a great episode. Tommy and Andy Power from Medics Money, I've worked with them both for the past few years. They never fail to deliver. And this episode is going to make you think, and Andy, I really do think you're going to need to watch this one.
What are you talking to them about?
So we're talking about how to get your practice in financial shape for 2026. Okay. So if you're a GP partner, this is a no-brainer. Yeah. You can put it down on your appraisal toolkit. It's 40 minutes, I think it is.
I'll call it an hour with some reflections, Gandhi.
There you go. But it's going to be an amazing episode. And coming soon, something really big coming on the channel that's going to take up some of the live streams I've got for the next 3 months or so. Andy knows, but he's not allowed to tell anybody. Going to be telling you all soon, but it's pretty impressive. I have to admit, I'm quite excited for it. So hopefully you'll all be as well as we share that and coming in the coming weeks and stuff. So all I'm going to say is subscribe, ring the bell, so you can make sure you get all that content, and we will catch you in the next episode. See you later, guys.
Bye, everyone.